Welcome back to ST3 Hacks. In this episode, I'm going to be moving on to another high-yield upper limb topic for ST3 interviews, which is scaphoid fractures. Now, scaphoid fractures are common, but more importantly, they're unforgiving if missed. Interviewers use them to test whether you understand blood supply, instability, and long-term consequences, and not just immediate X-ray interpretation. And I think this is a shift that's happening in the interviews to try and test candidates further by not just having the common cases that come up in the emergency department. Now, how I frame scaphoid fractures. When I'm asked about a suspected scaphoid fracture, my priority is not just confirming the diagnosis, but understanding the risk of non-union and avascular necrosis. So before answering the station, you should always reset thinking around anatomy, blood supply, and fracture stability. Pathanatomy. The scaphoid is the most commonly fractured carpal bone. In terms of location, 65% occur at the waist, 25% in the proximal third, and about 10% affect the distal third. This matters because fracture location directly correlates with healing potential. So, the scaphoid has a retrograde blood supply, primarily from the radial artery, and the major supply comes from the dorsal carpal branch, which accounts for about 80%. There is also a small contribution that comes from the superficial palmar arch. Now, because of this retrograde flow, AVN risk is about 33% in the proximal third of fractures, and it approaches around 100% in the proximal fifth. This single fact should influence how you manage almost every scaphoid fracture. Now, unstable fracture patterns. So you should say, I actively look for unstable fracture patterns, including comminution, vertical or oblique fracture lines, proximal pole fractures, and some waist fractures, depending on the displacement and alignment. Unstable fractures are much less forgiving with conservative treatment. Moving on to classifications. Again, I don't dwell on classifications because the interview is so tight on time. But I do want to mention the relevant ones to show awareness, and I think as a good candidate, it's important to know this information. So the Herbert and Fisher classification is quite useful. Types A and B are acute fractures, stable and unstable respectively. Type C represents delayed union, and type D represents established non-union. There is also the Mayo classification, which describes a fracture location from distal to proximal, types 1 through 5. And there's also the Roos classification, which describes fracture orientation. First is horizontal, transverse, or vertical oblique. This helps identify instability. Complications. The two big complications that you should always think about are non-union leading to AVN, and also something a bit more specialized, and I think if you sprinkle this in, this will show that you're ahead of the game, is a SNAC wrist, which is a scaphoid non-union advanced collapse, which ultimately leads to degenerative arthritis. Another niche thing is the SLAC wrist, which stands for SLAC, scapholunate ligament disruption. And this is another type of advanced collapse due to the lunate bone being not aligned when the scaphoid has been injured. Moving on to the radiology. You should start by asking for standard wrist X-rays and assessing the exact anatomical location, displacement, and comminution. I would then request a scaphoid series, which includes the lateral, oblique, and a dedicated scaphoid view with about 30 degrees of wrist extension and 20 degrees of further ulnar deviation. If there's still diagnostic uncertainty, MRI is my investigation of choice. The key concerns here are that scaphoid fractures carry a high risk of AVN due to their blood supply, so a normal initial X-ray does not rule out injury, and missing the diagnosis has long-term consequences. So the guidelines and principles here are following the triple assessment model: history, examination, and appropriate imaging. In the history, you should focus on mechanism of injury, typically a fall on an outstretched hand, pain using Socrates, hand dominance, occupational and functional demands, smoking status, a quick ample history, particularly if there's any anticoagulation involved, and smoking, which is especially relevant due to its effect on bone healing. The examination you should do in a look, feel, move manner with a full neurovascular assessment. Specifically for the scaphoid, I would say something like I would assess anatomical snuffbox tenderness, test the scaphoid tubercle for tenderness, and perform an axial compression test of the thumb. Positive findings here significantly increase suspicion. In terms of initial investigations, I would ask for X-rays, and if they're inconclusive, but the clinical suspicion remains high, I would immobilize the wrist and arrange an urgent MRI, which is the gold standard as per NICE guidance, and follow them up in our hand or fracture clinic. Management, again, would be centered around immobilizing the wrist in a short scaphoid cast or wrist splint, providing appropriate analgesia, and arranging an early follow-up in hand or trauma clinic within 1 week. Definitive management should be discussed with a specialized hand surgeon, and an MRI helps here to guide whether treatment should be conservative or operative. Conservative management is usually appropriate for undisplaced waist fractures, typically less than 1 to 2 millimeters of displacement, and also for distal pole fractures. Union rates exceed 90% in these cases, as shown in the SWIFT trial, although proximal pole fractures were excluded. Patients should be strongly advised to stop smoking to optimize bone healing. Moving on to operative management, as a candidate, you should be aware of what the options are, but they don't expect knowledge that is very specialized from you. So you can say that operative fixation can be considered for the following situations: delayed union, displacement more than 1 millimeter, associated perileonate dislocation, unstable vertical or oblique fracture patterns, comminution, proximal pole fractures. And then here some golden points are that radiological indicators that suggest instability include a lunocapitate angle greater than 15 degrees or a humpback deformity with an interscaphoid angle greater than 35 degrees. These are really like niche stuff, and I don't think you need to know them, but just have them in case as you build your interview repertoire. Surgical options include percutaneous compression screw fixation or open reduction in internal fixation, depending on the fracture pattern instability. If you remember one thing for scaphoid fractures at ST3, it's that you treat the blood supply with respect, immobilize early, and you cannot rely on normal x-rays to reassure you. That's it for this episode of ST3 Hacks, and I'll catch you in the next one. Thanks.